Hello everyone, I'm going to record a brief lecture video on the assessment of the head and the neck. Alright, again we're going to do a few focused history for the assessment of the head and the neck. Ask them if there's any history of any injuries, any masses or lumps, any pain or limitation of the movement of the neck, mostly the range of motion. Do they have a history of headaches? Does your client have a history of headaches? What type of headaches do they have? Do they have a history of just general headaches, or do they have a history of migraines? Anything of that nature. Any difficulties with the head, neck, or particularly the thyroid? Enlarged thyroid, hypothyroidism, hyperthyroidism, any surgeries in the head, neck, or thyroid area, or any type of trauma. So just make sure to get a focus history. See if there's any abnormals or any history that might be concerning for your client. And again, remember, we're going to start with inspection, then we'll move to palpation, and then auscultation. The head, we like to see that it's centered on the body. It should be erect and steady. Any type of bobbing or tremor might indicate that there's a cardiac problem or a perfusion problem if they're trying to having some issues. It also may show that there might be some underlying neurological problem. For a normal adult, the head is 1/8 the size of the body. Again, 1/8 the size of the body. For an infant, it's about 1/4 of the size of the body. And as they grow as infants grow up through toddler and on up, it seems to become more proportionate to the adult size. The head should be fairly symmetrical. They may have a different shaped, round, square, oval, oblong. Anything asymmetrical might be caused by something genetic, such as dimples, which is minor, or there might be some type of underlying medical issue or trauma, such as nerve damage. Botox does cause some nerve damage. It basically paralyzes the nerves in different areas of the face to decrease wrinkles and trauma. So you're going to do just a general inspection and palpation of the skull. You're going to feel just for general contour shape. It should be nice and smooth and symmetrical and free of any type of masses or lesions. Feel free to use your gloves if you're uncomfortable palpating the head without gloves. On my video, I used no gloves because it was my son, for one, and two, I just didn't have access to those things right now. It's the college has donated their supply to the hospital when they were needing supplies due to the pandemic. Then range of motion for the neck, again, flexion. That's when the client puts the chin to the chest, and you'll have them do each of these movements individually. So chin to chest for flexion, put the chin to the ceiling for extension, and then have them do chin to shoulder each side, and that's the rotation, and then ear to shoulder, and that's for the lateral movement. It should be able to move freely without any pain. You shouldn't hear a lot of cracking. That's crepitus. Those are the noises like the bones cracking. Ideally, as long as they're moving slowly, they really shouldn't get dizzy, and hopefully they have no stiffness or rigidity with those movements. The symmetry of the neck, there's a lot of musculature in the neck. We're just assessing for general symmetry. You have the sternocleidomastoid and the trapezius muscles that help surround the neck. Just inspect and palpate in general. The trachea, this is very important. This would be a part of your head-to-toe assessment, just at least upon inspection. You always want to make sure that the trachea is midline and not deviated. You're basically you're going to use your hand and just feel along that trachea to make sure it's where it needs to be, midline within the neck. You'll put a thumb on each side of the trachea just to measure if there's equal distance between the trachea and the sternocleidomastoid. As you can see there. there are some underlying respiratory conditions, some trauma that may happen with traumatic pneumothorax that can cause deviation of the trachea, and it's a true life-threatening emergency. So we do like to kind of look at the trachea to make sure it's nice and in center and midline. And again, here's it should be normal, straight, midline without any tenderness. Abnormal would be if the trachea was deviated or shifted to one side or the other, or may have some tenderness. Just as I talked to, possible causes could be a tumor, maybe the thyroid, there may be underlying thyroid issues. That lung problem, which I described, it's usually in an emergency, or enlarged lymph nodes. They may have some, there may be some tenderness on palpation. Again, that would be listed as abnormal. Just a review of the structures of the neck. You can see the hyaloid bone. Here's your sternocleidomastoid. The thyroid cartilage, the cricoid cartilage is right here, and the isthmus of the thyroid. The thyroid gland is in here. It's typically surrounded by the parathyroid. The trachea itself is underneath that in this tiny little area there. And here's your clavicle bone for reference, and the top of the sternal border, or the top of the sternum right there, and then the manubrium of the sternum. The thyroid, again, this is not something that you would do on a normal head-to-toe assessment, but thyroid problems are, particularly thyroid conditions, thyroid surgeries, are not that uncommon. And so if you do have a client with a thyroid problem or a thyroid surgery, or that has had thyroid surgery, you should learn to do a more focused assessment on the thyroid. Again, you're always going to start with your inspection and then move to palpation. The thyroid should be very visible. It might be seen just like a little thickening of the neck when the patient swallows. We kind of have them hold their neck up and give them a little bit of swallow. It looks a little thick, just right above where the trachea is. Again, the abnormal finding would be that they have either unilateral or bilateral enlargement of those lobes of the thyroid in the neck. There you are. Again, here is the thyroid here, and there's the lobes of the thyroid. There is a particular technique. I'll just describe it. You don't have to just demonstrate it for us for this class. But you would basically have them swallow, find the isthmus, and then just have them tilt their head to one side with the fingers of one hand, sort of like displace that thyroid toward one side as the head's tipped. There are a lot of videos out there on how to assess a thyroid. Just to be familiar with how it's done. Again, it's not something that you're going to be responsible for demonstration, and I don't believe it's on the exam as well. But we're just kind of looking at the size to make sure it's not enlarged. The consistency, because sometimes thyroid problems make the thyroid tissue a little bit more granular. So we're checking for the consistency, any type of nodules or tenderness. And they have both an anterior and a posterior approach with the thyroid assessment. Here you can see that she's found the isthmus on the left side there. And then they're standing in front of her, and they're palpating each side on where the thyroid tissue is from that anterior approach. And this is the posterior approach. I actually see this one done more frequently versus the anterior approach. They have them tilt their side of their head over, and they kind of work their fingers into that little groove and feel for that thyroid tissue. Again, normal findings, they should be non-palpable, and if they are palpable, it should be very, very small. They shouldn't hurt, and they should be freely rise when they swallow. They should be able to move easily when the client swallows. It should be firm and pliable, and again, the right lobe is usually a little bit larger than the left. What's abnormal with the thyroid of these findings, if the lobes are enlarged or easily palpable, if they're extremely tender or any type of tender on palpation, that would be a concern. Any type of lumps or nodules within that thyroid, again, is absolutely something we want to refer to a provider. The thyroid should, if it's not fully movable, if it feels like it's connected to the underlying tissue, or if the tissue itself has a different texture to it, like it feels coarse or gritty, that might show that it might be some inflammation or some other concerns going on. And this is just some symptoms and signs and symptoms of altered thyroid function. We won't get into more detail with that until you are in your nursing course. I believe your second semester. But hypothyroidism is extremely common in a lot of your clients. And their hyperthyroidism not quite as common, but it does happen. You won't be tested on this information, but just be aware that it's extremely, extremely common in a lot of clients. The lymph nodes. To assess the lymph nodes, you're just going to gently feel the lymph nodes and just a gentle palpation, just easy circular motions on each area of the lymph nodes. Again, too much pressure will make them kind of like push away or push off to the side or go deep. You're going to use both hands because you want to assess side to side. You want to make sure that they are symmetrical. And try to use a systematic approach so you don't miss any of the lymph nodes. I do demonstrate this in my demonstration video. You do the pre-auricular, which is just in front of the ear, in front of the pinea. Your post-auricular, which is behind the ear or behind the pinea. The occipital, which is back at the nape of the neck. The tonsillar, which most people are familiar with. Those are your tonsils, where your tonsils are located. Submandibular or submaxillary is under your jaw. The submental is under the chin. That cervical chain basically follows along where that sternocleidomastoid muscle is. And then you have your supraclavicular, which is on the top side of the clavicle, and you have infraclavicular, which is on the bottom side of the clavicle. Just a general assessment. We like to feel all those lymph nodes, kind of where they are, and make notation of those. Here's a pictorial of kind of where they're loaded. Here's your pre-auricular, post-auricular, occipital, submandibular, and this is your submental. Here you have your, this is your cervical chain down through here, and then you're going to have your supraclavicular and your infraclavicular down below. Again, you're just going to kind of note the size, location, what the shape are, if they're discrete or matted together, if they're freely movable or fixed, if what the consistency is of those nodes, if you can feel them, and if the client has any tenderness. Most of your lymph nodes should be non-palpable. Occasionally, if there's some inflammation going on, or even some allergies or some issues, you might be able to feel the thyroid. Not the thyroid, the tonsils. But for the most part, they should be non-palpable. And if they are palpable, it should be very small and they should be non-tender. What would be abnormal if the lymph nodes are enlarged, if they have a lot of tenderness, if they are warm, fixed, hard, firm, that shouldn't say form, that should say firm, or if they feel like they're nodular. An enlarged lymph node where you cannot determine the source of the problem demands some prompt attention. We always just try to refer that on to a provider if we do discover this in one of our assessments. Again, clues to problems. Remember, we don't diagnose, but we just kind of gather information. But acute infections, sometimes the nodes may be enlarged and a little tender and formed because the lymph system is a part of your immune system. Chronic inflammation, sometimes the nodes can be clumped together, particularly like something like a TB infection. Cancerous nodes are usually hard. They're unilateral, so they are not symmetrical from one side of the body to the other. It's usually one side of the body. Not always, they don't always have a lot of pain, but they are fixed to the underlying tissue. They're not freely movable. You can't kind of wiggle them around. And remember, we don't diagnose, but anytime we find some enlarged nodes, you just want to make sure to mention that to your physician, or to your client's physician, or to their to a higher level provider. Some of the geriatric variations, again, they get more wrinkles and bones of the nose and face. They lose some of that muscle tone, lose some of the elasticity in their skin. So they tend to they should have more prominence. That's the word I'm looking for. The neck may become a little bit shorter because of the muscle atrophy and loss of fat, and also because of the cervical changes in the cervical spine, and the decreased flexion, again, because of arthritic changes and or osteoporosis. And again, you typically see that in women post-menopausal and also in men. That dowager's hump, that's kind of like and you've probably seen it on other people, perhaps a family member or someone, or maybe even in a movie. But it's kind of like that little hump when little old ladies get older and they look like they're kind of like hunched over. It has like a little fat that accumulates around the cervical neck. The thyroid, again, with the geriatrics, it may feel a little bit more nodular and irregular. It's just some fibrotic changes that can happen as they tend to get a little bit older. There aren't any really variations for your pediatric clients for any of that. All right. If you have any questions, please let me know. Thank you very much.